Can everybody see the screen now?
Yes.
Okay, good, thank you. I feel very isolated being thousands of miles from everybody, and I like to hear your human voice. I'll be glad next year where we could all be together again and actually interact with each other. So like most of you, I'm tired of the Zoom generation. So, okay, let's talk about, this goes along with preeclampsia. We're talking about cardiac and pulmonary disorders. At the very end, I've added some slides on COVID management during pregnancy, and our internists and intensivists are so busy they don't want to deal with our pregnant patients. So until they go to intubation, they're pretty much ours to take care of, and want to go a little bit over COVID and pregnancy at the very end of this lecture. Okay. There'll be several abbreviations used in this lecture, and you can see what they are here. I'm trying to get my screen better here. Okay. You'll see these used in the lecture today. It's interesting, when I trained many years ago, we didn't see too many people with congenital heart disease because they just weren't getting pregnant at that time. And they're lucky to be alive. But now with better technology, heart surgery, etc., pregnant women with congenital heart disease are getting pregnant now. And the reality is they're 100 times greater to have significant mortality and congestive heart failure compared to women who don't have heart disease. So it's incumbent upon all of us to have a basic understanding congenital heart disease, and when do we need to call the cardiologist? When is it probably no big deal? When do we need to transfer these to a higher level of care at that point? And none of us are cardiologists. I'm certainly not a cardiologist, but I think at the end of the lecture today, I want you to have an idea of what you can manage yourself in a community hospital. When should you transfer? When should you get a cardiologist or others involved? Let's talk about a little bit about physiology. This is just the anatomy again for those who forgot about the heart. One of my mentors once said the heart has one function, that's to pump blood to the uterus. But unfortunately, when you're pregnant, this heart gets in the way sometimes. So we have to do a little bit of anatomy. But again, remember, the blood comes from the vena cava into the right atrium, tricuspid valve goes to the right ventricle, pulmonary valve to the lungs, back to the pulmonary veins, the left atrium, mitral valve, and out to the aortic valve to the systemic system. We're going to talk about myocardial infarction. You don't need to know the coronary arteries, but if you see these in some of the literature, there's two main ones to the left and the right coronary artery, and the left one divides into the these two, as you can see, the left anterior descending, and as well as the marginal artery. They anastomose posteriorly to form this form this posterior artery posteriorly. On the lungs here, although this seems very simple, when we look at chest x-rays, it's important that the inferior lobe is over here way to the right, and a lot of times you'll see infiltrates down here. I'm going to show one later, and you think, oh, that must be the inferior lobe. That's actually the middle lobe on that side, and I'm not going to bore you with the subclassifications of the lobes here, but when you look at chest x-rays, it's the middle lobe does drop down quite a bit, and a lot of times it'll actually drop down further than that during pregnancy. We talked about this already. Blood volume goes up by 50% during pregnancy, and around term, one has about 100 mils per kilogram. So if you're a 70-kilogram woman, your blood volume is about 7 liters, and we see a fall in the hemoglobin due to hemodilution. Cardiac output does begin going up in pregnancy, and you may remember from medical school that cardiac output is the stroke volume versus the heart rate. So we see stroke volume, heart rate both go up during pregnancy, but the afterload, which is peripheral vascular resistance, diminishes, and that's due to the vasodilatory effect of progesterone. And we do see some left ventricular hypertrophy and dilation during pregnancy, but the contractility is pretty much unchanged. The preload increases in pregnancy. That's what's coming back from the vena cava. That's due to increased blood volume. And during labor, every time the uterus contracts, that dumps about 300 to 500 cc's of blood temporarily back into the maternal circulation. The afterload diminishes, and that's due to the effect of progesterone. Blood pressure, by the way, is a surrogate marker for peripheral vascular resistance. In twins, cardiac output even goes up higher, about 20% higher compared to singleton pregnancies. And during labor, it goes up even more. I mean, can you imagine what a stress labor and delivery is on the heart? And this is due to sympathetic stimulation and pain. And again, I think most of us know that mean arterial pressure, which is MAP, goes up about 10 millimeters per mercury during a contraction. So if we're monitoring somebody severe preeclampsia, we really don't want to take their blood pressure during contraction. But most of the time we have these little contraptions to take the blood pressure for us, and the nurse is not doing it. And one of the questions I would always ask the nurse is, did you take with the pressure taken during the contraction? And so there may be benefit of repeating blood pressures before treating them in severe preeclampsia. Back to this lecture. So we see the cardiac output go up 50% during the pushing effort and immediately postpartum. We've all heard about putting patients on their left side, and this increases the preload, the amount of blood coming back to the uterus, and that helps with the cardiac output as well. So, so those who have issues with getting blood to the placenta, this is why our nurses put patients on their left side. Immediately postpartum, mentioned cardiac output goes up tremendously, and this is due probably to the autotransfusion phenomena. That baby's delivered, you have the placenta out, that uterus hopefully contracts down nicely, and we all of a sudden have 300 to 500 cc's of blood just placed into the maternal circulation. Cardiac output and the vascular volume do decrease slowly to about 3 months, and that's why, again, women have this huge postpartum diuresis. They're trying to get rid of some of this excessive serum volume they've built up during the course of pregnancy. There are also changes in EKG. For those who forgot about EKGs, here's the waves over here. But we see left axis deviation, and you may see interesting things like flattening of the T waves. And sometimes inversion of the T waves in 3 and V1 through some of the anterior leads on people as well too. These are all normal. Most cardiologists are aware of these, but if you happen to get an EKG before the cardiologist reads it and sees this, realize that these things are normal during pregnancy and not emblematic of acute myocardial infarction or anything like that. There are respiratory changes. The diaphragm goes up, that baby pushes everything up, and the respiratory rate goes up during pregnancy because of the increased oxygen needs. Tidal volume goes up about 40%, and generally there's a mild respiratory alkalosis. Women are breathing off this carbon dioxide, and so their PO2 may be a little bit higher and PCO2 a little bit lower than in a non-pregnant individual. This is a classification of cardiac disease. If there's anybody listening from Canada, the Canadian and US terms are pretty much synonymous here. I put both of them. Generally, if you're a New York classification or cardiac or Canadian classification 1 or 2, you have a favorable pregnancy outcome. 1 is no limitations. 2 is just slight limitations of activities of daily living. But classes 3 and 4 generally carry a very high risk of morbidity, mortality. Hopefully those with these are not going to get pregnant, but guess what? They sure do. and walk in and you just go, oh, this is not going to be a good outcome when they come in 20 weeks pregnant with things like this. And in fact, in my community here, our maternal mortality is is always 50%, at least 50% of those who have congenital heart disease, who got pregnant, who did not receive early prenatal care, who come into labor and delivery of the emergency room in failure. So class 3 is marked limitation, and class 4 is they can't really do much at all without acute discomfort. In the United States, a third of maternal deaths are due to cardiovascular conditions. And as I mentioned in my institution, my community, we've looked at these, it's really higher than this. And a lot of this probably is due to living in Texas, and we have a lot of people crossing the border who've had no prenatal care or knowledge they had a congenital heart disease and come in and cardiac failure. Let's look at some of the disease and some of the structural diseases. And again, for us as practicing OB-GYNs, we need to know a little bit about this because we want to get a cardiologist involved early. Others probably don't need a cardiologist. And but more women are getting pregnant. We're just getting better at getting these babies through pregnancy. They grow up, they have various heart surgeries and things, and now they're getting pregnant as well too. But anybody who has a congenital defect does have increased risk of having an arrhythmia and heart failure. And you can see in this little picture over here that we're just seeing more and more of these in our L&Ds throughout the US and Canada now. Here are some of the things that may develop in those who have congenital heart defects, and it's just a parade of horrors, as you can see from the list there. Here's the evaluation. If somebody has known heart disease, prior cardiac surgery, et cetera, you probably, they're going to have a cardiologist on board, but if you don't have one, you probably need one. And get a list of their medications. Certainly you want to get an O2 stat, EKG, echo, and whatever the cardiologist wants to get. Besides the basic lab work that we're normally we get, you'd want to get a baseline BMP or B-natriuretic peptide. I'm going to talk about that in the next slide. And you may want to get MFM involved, particularly they're going to be transferred, and genetic counseling, because often the maternal cardiac defects do have a genetic component. And during the course of the pregnancy, fetal echocardiography is generally indicated in all women who have a congenital heart